when should I start jogging, when should I start walk to my apartment. So the lack of education is also sometimes I feel it is a poor. It could be because of various reasons. In the hospital, initially surgeon has not advised, initially physiotherapist is not advised, later on the family physiotherapist is not advised. Could be the various reasons, but it is not the solution. We'll see. Because of poor balance, poor education, poor gait pattern, poor knee bending, functional activity, especially the step climbing down, walking around the park, walking around the house is difficult for them. So the functionally they are not at the best level what they should be. The eccentric strength of the quadriceps is one of the key component of these things. If eccentric of quadriceps is weak, the patient will not able to sit on that commode, will not able to go to the step up or step down both. And lastly, yes, surgical pain, and sometimes it's a chronic pain, it's a pain in the mind. Could be because arthritis is a chronic condition, and chronic pain, half the pain is in the knee and half the pain is in the brain. So now knee is treated, knee arthritis is not there. So now still they complaining of pain after 6 months. You can think of central nervous system pain. So these are commonly found physical complications after a knee replacement patient. What I generally, the question is something called post-surgical inflammation. They have cut the skin, they have cut the fascia, they have removed the all the muscles, they have cut the bone. So there will be some amount of joint effusion, joint pain, joint inflammation. Calf, why calf? Because origin of gastrocnemius is from the condyle of the femur. So some amount of swelling on the gastrocnemius is expected up to 3 weeks. After all kind of replacement surgeries, because the major surgery has been done, so post-surgical inflammation in the surrounding soft tissue or inside the joint is expected from 2.5 weeks to 3 weeks. So if it is there, I feel it's fine. It's fine. If we can go ahead with the crab bandage, compression, elevation, rest and ice, it should not be a problem. You said one leg is fine, other leg is problem. Could be the biomechanics, how her walking style, how is her use of muscles, how, because most of the patient who have a hamstring weakness, they use the gastrocnemius. We'll discuss in the biomechanics. Okay, so that could be one of the reason. Nurse or co-contracting, they're co-worker, they're working together to get the work done. Now suppose after TKR the patient is having poor quadriceps, grade 3 minus or 2, how he will walk? He'll walk like, as soon as in the mid stance where the quadricep roll is required, it's not happening, it's buckling. So that is one common reason. Let's have a good quadricep but poor hamstrings. A poor hamstring is there, what person will do? Hamstring roll is to pull the tibia back, and do the knee flexions. Now hamstring is poor, so knee flexion is not there. Now still knee has to flex. Who will do that? There are other factors. Soleus can do that work. It can compensate the work of hamstrings. Now if suppose soleus is also weak, someone has to do the work, then the other muscle is, could be hip extensor. It has a both connection actually. Hip flexion, knee flexion and knee extension both actually sometimes. It's a hip flexion. The knee flexion is some controversial role that gluteus do knee flexions. But sometimes when the quadriceps is poor, the person do femur back by gluteus femur back so that they can do knee flexion if there is a quadricep weakness, and that is why a lot of activity of gluteus maximus, the pain start on the pelvic girdle or lumbar region because the muscular balance has been changed. The sagittal plane stability of the pelvic girdle got changed. One muscle is using too much. Now another function, that's what I said, if gastrocnemius is weak, hamstring is weak, third function can be done by iliotibial band. Iliotibial band at 15 degree of knee flexion is a hip like knee flexor. So it will start bending knee. But that is very common in the osteoarthritis knee people, that IT band is tight. All OA knee patients, all post replacement patients walk Trendelenburg gait or Wedling gait because of which muscle weakness? Gluteus medius. So gluteus medius is weak. The continuation of gluteus medius is IT band, right? So now there is no activity of gluteus medius. Gluteus medius is not contracting. If suppose this is the tendon, this is a tendon, this is a muscle, and this is a tendon. If this contract, this will stretch. Basic muscle physiology. This contract, this will stretch. So now the gluteus medius is weak. It is not contracting. So what happened to this? It is not getting stretched because there is no force. It is not getting stretched. So what is going to happen? That is why they have IT band tightness. That is my reason for me being agree with that term. So that is why the patient, most of the post TKR patient complain of pain in the lateral aspect. I have a pain here because they have a IT band tightness. The reason of IT band tightness is they have long term of gluteus medius weakness. It's not a post surgery. It has been long term. It is, they are having gluteus medius weakness since last 10 years. It's gone into disuse atrophy, and because of the disuse atrophy they have a tendon which has gone into tightness. And long term tightness, after the replacement, the anatomy has been corrected. So initially they were like this, but anatomy has corrected. So now the tight IT band is rubbing with your lateral condyle whenever they are walking, whenever they are doing any activity, and that's why they constantly complain of pain. Very common reason for this. This is not ACL patient, this is not TKR patient, but this is what commonly happen in the ACL patient. When I ask them to do the lunge, see the knee is going outward, knee is not straight. When the person is doing forward lunge, it is not going straight down, it is going straight outward. It is because of IT band. It is not going straight down, it is going straight outward. That's the reason of your IT band tightness. And that is, this guy is ACL post 7 week of ACL reconstruction, and same thing happen in the TKR patients, that they keep complain of pain. Now if IT band is tight, you know, when we walk mid stance or hill striker mid stance and terminal stance, our tibia moves in and out, internal rotation, external rotation of the tibia. What if external rotator IT band is tight? There will be internal rotation? There won't be internal rotation, or internal rotation will be limited. If there is a limited internal rotation, the stress on the medial aspect of the structures will be into the tension, because it's the constant external rotation. The structure what are here is going to be stretched, and that is also one of the possibility of getting the pain. Now what is the medial component? It could be MCL, it could be VMO muscle, it could be the pes sensorinus bursa, which is getting tense and it getting compressed because of the tension in the sartorius, semitendinosus and the gracilis. Could be anything. So that is why the rotation of the tibia is limited if the gluteus medius is weak or IT band is tight. If that is weak, this could be one of the possible reason of pain at the knee after the replacement because of flexibility issue. If the one side lateral aspect of tibia, lateral aspect of thigh, IT band is tight, what about the patella tracking? Will be? Patella tracking will be disturbed because there is ideally the three forces are acting: rectus femoris, vastus medialis and vastus lateralis, which makes patella straight up. Now if vastus medialis is less and vastus lateralis, or because of the IT band the patella excessive, so the ground force will be like this. If the patella is going like this, it will continuously rub on my lateral condyle of the femur. So if I am doing this, my patella is, instead of coming straight up, it's going straight outward and it's come rubbing on my patella. One other possible reason of pain. Now most of the patient complain that my pain is when they do terminal extension. They can do this, they are freely, whenever they are sitting they keep doing this, but they don't do this, they don't make it knee straight. Why? Because of the line of force. When they are 90 degree, the line of force is no contact, no compressive force between patella and femur. The patella is away from the femur and that's why no compression force. But when the knee is 90 degree, 45 to 0 degree, there is a direct compressive force on the femur and patella. Another reason of pain possible, biomechanically, and because of surrounding tissue tightness, IT band, VMO, soft tissue, the patella mobility might disturb, and that is another reason of stopping functional activity. If there is a soft tissue stiffness, around the knee joint, if you go and bend your knee, it will gonna pain. The patient said, "Oh, I can't go beyond 90 degree," because the reason is everything is tight. So either you release the tightness first and then you bend, it will be much better. So that's what will happen. Patient is TKR, we made them prone, bend the knee. So generally they able to bend is 60 to 70 or 80 max, and most of the patient after the 7 week or 6 week they get 90 degree, but beyond 90 degree is the difficult task because of the stiffness, because of the retinaculum, medial retinaculum, retinal retinaculum, quadriceps tendon, patella tendons, IT band is all are tight. They are not allowing me to go further bend, and that's why they complain of pain. The pain is not because of the stitch or inflammation, it is a tightness. When you do further push, there is a short term pain, but because of push, the collagen fiber, what the stability, because of the fibrosis there was a tightness. Tightness means fibrosis. So that fibrosis is getting break. The fibrosis is getting break, second day there will be an inflammation of that broken fibrosis. That's why I say, oh, yesterday you pushed my leg, today is my paining. That is the reason. And that pain will be there for 48 hours because of the inflammation settle down in the 48 hours. So that is what the reason is. So initially, before we bend, if we can release by some soft tissue release technique, the tightness, you can better the knee, you can bend the knee better and painless or with minimal pain. Again, same example for IT band tightness. Okay. Now let's knee flexion deformity, FFD. What are the complications we find generally when there is a FFD? Can you expect normal walking gait with knee bending? We cannot. If a patient underwent, I have a patient who operated in Chennai 8 months ago. He is having 10 degree FFD constantly. Now, if I make him walk, he is not getting normal walking style, because I cannot expect that he will get a normal walking style, because the knee is not going into extension when he walks. At heel strike we want knee to be complete straight. At mid stand we want knee to be complete straight. If knee is not straight, obviously I can't expect the knee is going to be completely or walking style completely good. It's not going to be.
The joint is worn out. The normal cartilage is not there. So normal, smooth, graceful movements cannot occur in the joint. That's it. That is the basic this thing. So what happens in this case? All the cartilage either gets eaten away due to disease like rheumatoid arthritis, or gets worn out as in degenerative arthritis. Whether it is the hip or the knee or the ankle or shoulder, it is the same. But we talk more about hip and knee replacements, mainly because these are the weight bearing joints and very important. So if these joints are not functioning, patients will not have normal gait. They will walk with limp deformity, difficulty in walking. Okay, so what is knee replacement then? Knee replacement or hip replacement for that matter is a surgery where we go and clear this degenerative or arthritic or worn out joint and replace it with a artificial material. This artificial material is made up of an alloy, mostly it is cobalt chrome, titanium alloys, and for smoother movement usually we put a plastic in between this metal. So if you see the top component is the femoral component, the lower component is the tibial component, and the piece in between is a plastic. All these materials have undergone lot of technology change, lot of improvisation, and today we have some of these best materials in this, which will wear out after many decades. Actually, earlier it was 5 years, 10 years, then it became 15 years, 20 years. The materials which are used now can last more than 20 years, and I have seen patients who have been in the artificial joint for 30 years, 40 years, and the present material may last even longer is what is being speculated. Okay, so after the joint replacement, now we are following a modern protocol in which there is no rest after joint replacement. This is one of the, we do not advise rest to any patient. So as soon as the patient comes from the operation theater, if she is good, talking, and then the first thing we do is make them get up, make them sit up in the bed like this. This is 5 minutes after coming back from the hospital, from the operation theater in the ICU. Okay, so we just make them sit up and get up and walk. But the most important thing is, this is not a rule. That all patients should get up and walk is not a rule. So because somebody is 50 years, somebody is 80 years, somebody is 90 years. So if you expect all, and they will have multiple comorbidities, and if you expect them to get up and walk, everybody to get up and walk, it may not be fair. Okay, so this is where our presence of mind is required, and go very slowly. Physiotherapy about very slowly mobilizing or doing everything. So talk to them and look at their orientation. So look at their breathing, look at their saturation. Anyway, they are connected to monitor. And if everything is normal, ask them to breathe. Breathing exercise is the first thing we should do. And then what we do is make them sit up. And if they are comfortable, no giddiness, then make them turn to the side and sit like this and do exercises. And if they are comfortable with that also, then make them get up and then make them walk. So at any point you see a grimace in patient's face, you should stop there. And it's very important to know what are they getting for pain, which will again dictate how you should mobilize. Like for example, if they have received a femoral block, so that means they will have quadriceps weakness. So they will not be, so if you ask them to walk, they may just fall. So you should know this. Is the patient on femoral block? Is the patient on epidural? Do they have quadriceps power normal or not? So all these things after that. So if they have a quadriceps weakness, you should put them on a brace, and still the other leg is normal, you can get up and walk. Okay, so and epidural also, many a times it is dissociative anesthesia, like that. Only pain fibers will be affected and motor fibers will be normal, but in any case you should test it, because it's not, they can't look at pain fibers and then only give. It is just a technique which is given, and most of the times only pain fibers are affected, but many a times even motor fibers are affected, so they may have weakness, and if you make them get up and walk, they might fall. So it is a disaster to happen. Okay. Okay, so day one, we should be very happy if the patient is smiling like this and walking in the corridor and is able to go to the toilet. About 80 to 90% of the patients will be able to do it, but 10% of the patients still may not be able to do it. So we should go slow. That is very important to assess them very slowly. Okay, day 2 or 3, so they should be able to do stairs if the progress is okay, and most of our patients are able to do that. Some of them, older patients, multiple comorbidities, they may not progress so fast, so give them time, so no need to hurry. Okay, so day 4 or day 5, usually all our patients are ready to go home. By this, what is the criteria for discharge? The criteria for discharge is that they should be able to get up on their own, go to the toilet on their own, and come back and lie down on their own. These are the discharge criteria. And another corollary is they should not be on injectables for pain. They should be on oral medication. This is very important. Okay, so if there is no pain relief, we should give pain relief and then send them. You should not say, oh, it's okay, you go. You should not. They should become comfortable. So what is adequate pain relief? The adequate pain relief is VAS score of less than 3, or after exercise, when they do, obviously the pain will increase, maybe up to 4 or 5. But if it is more than 5, then it is not. So don't push them if the VAS score is more than 5. Okay, so if within 2 weeks, if our patients are able to do this, is a fantastic recovery, unbelievable recovery. Okay, so this is our own patient. This video is shared by Arun. So that is one way of keeping in touch with the doctor is you keep on updating about patient to the doctor. Now with WhatsApp and so many, gadgets, it is so easy to keep in touch. See, if you tell, so your patient is doing like this, just imagine how the surgeon will be flat. So whoever it is, so okay, I know what is happening. Many a times I won't know what is happening with the patient. So till they come back after 2 weeks for stitch removal, or they come and land up with a problem. So whereas our physio is visiting them every day and they don't inform us that the patient is having pain, that the patient's wound does not look right, all these things. Okay. So hip replacement is similar but not the same, because in knee replacement the commonest way of doing knee replacement is a cemented knee replacement. Okay, uncemented knee replacement is not very common in our country, anywhere in, for that matter. Worldwide also it's not very common. Okay, so but in hip replacement you have cemented variety also and uncemented variety also. So the uncemented variety is the commonest. 90% of the time or 95% of the time we do hip replacement without cement. Why I am telling this so much is, that is before surgery, and this is, so why I am telling this so much is, it is very important to know that in an uncemented hip replacement, the integration, bone should integrate with the implant, artificial joint. So that has not happened immediately after surgery. It takes, how much time does it take? It takes 3 to 6 months for integration. So it's very important to remember this whenever you are mobilizing hip replacement. So if it is uncemented hip replacement, so you cannot allow them to walk as freely as a knee replacement. Like some time back he was asked, or somebody was asking, when do we ask them to leave the walker? So in knee replacement, as soon as they are comfortable and they are able to walk, they will not even ask you actually. If they want to come to you, then they might bring and show you that. So actually at home they are not using it. So that is, they will only stop using it. So but in hip replacement, we prefer them to have at least a walking stick for a period of 6 weeks. Why 6 weeks? 6 weeks is the time when at least 50% of the bone integrations happen, and by 3 months to 6 months full integration can happen. So if nothing has happened in 3 months or 6 months, so you can, although you may not see anything on the x-ray because it is osteon to osteon healing, that kind of integration. If nothing has happened, patient is pain free, you can see, you can presume that everything is going well. Okay, placement will look like. Okay, so in any case, now the modern protocols for mobilization indicate, or what we practice is we allow them to bear weight as tolerated, that is almost full weight bearing, but the only thing is we ask them to keep either a walker or a walking stick. This is because it's an uncemented hip. Okay, so in such a case, or the boy you saw, so you can always ask them to full weight bear immediately, but with a patient on a daily basis, in the whole team, you have surgeons, you have assistant surgeons, you have fellows, you have nurses, you have everybody, all of them are not in touch with the patient. Okay, so you are the only person, so this is the time when you should watch pain, because increasing pain can mean anything. It can mean a periprosthetic fracture, it can mean infection, it can mean anything. Okay, so watch for progress. So every day the range of movement or whatever it is should improve. If it is not improving, you cannot keep quiet. You should discuss with the doctor. So this is not progressing as much as I thought it should progress. So do you want to see the patient? Okay. So, and most important thing is wound complication. You should have a look at the wound. Okay, so if the dressing is clean, patient does not have pain, you don't have to do anything. If the dressing is not clean, or it is leaking, or there is redness, there is swelling, there is increased pain, every time you try to mobilize, the patient is not comfortable. He was very comfortable on day 2, 4, 5. Okay, but now he is not very comfortable. That is an indication of either superficial wound, because that is how alert they are. Okay, so and of course you should be watching for DVT complications and wound infection as such, and so immediately call the doctors and communicate. Okay, so this is what I thought I will share it with you. I am okay to take any questions you want to ask about surgery. DVT, yeah, cough swelling and cough pain, first thing you should think about. Yeah, as some swelling is normal to get after any surgery. Forget about knee replacement, hip replacement. The foot and ankle swelling and the whole leg swelling is common after any surgery or injury. So especially when they are leaving the legs down most of the time. So this is a normal phenomenon. So I do tell my patients that you expect leg swelling, especially after you walk, sit for a long time for the next 1 or 2 years. Okay, this is normal. Okay, but at the same time it is a dangerous sign, especially if there is a cough swelling where if you touch it, it is like a rock. It's an indication of deep vein thrombosis. And if you squeeze the cough, if the patient has severe pain, again an increased indication of deep vein thrombosis. And if you stretch the foot like that and it produces cough pain, not the wound pain, then again it is an indication of DVT. Okay, some swelling of the leg, foot, ankle is normal after surgery, but if it is beyond a certain range, it is a dangerous sign. So, and continuously you should keep a watch. So there is swelling, there is pitting edema, and the patient typically tells, oh, it is not there in the morning and it comes only in the evening. So then you don't need to worry. Okay, because this is a typical edema. Why this edema? Probably it helps to know why it happens. So it is not due to your surgery or any of the injury. It is because no vein, this thing and all. But this edema, what you see, it's called edema, pitting edema. What you see is mainly due to obstruction of the lymphatics. Is not due to vein or artery. It's obstruction of the lymphatics. So when you put an incision or there is any injury,